Good evening, everyone, and Happy New Year. We are very excited to present our second webinar focusing on the PPED project, which is the Postpartum Preeclampsia and Emergency Department project, which focuses on recognition and response to postpartum preeclampsia. And this webinar is recorded. We will have a number of breakout sessions, have time for questions and answers. We're excited about kicking this second webinar off. And so let me first introduce the presenters. Next slide. And so I'll do the introduction. I'm Jim Hill. I'm the TCHMB OB co-chair, and I'm also the one of the co-chairs for this particular project. My TCHMB OB co-chair is Gloria Delgado. She'll also present today. And then we have Lolly Perry, who is also on the faculty for this particular project and a member of the TCHMB OB committee member. She'll present some information. And then Mercy, who is the PPED program manager and also on the TCH OB committee, will provide some additional information. And then we'll have some updates from some of our other faculty members that I'll talk about here shortly. Let me just kind of give you an idea of what we're going to talk about today. Next slide. So like I said, I'll kind of introduce the work group, and I'll kick it off and give it to Lolly, who will give you a little bit more background, a little bit more detail on the structure of the project itself. And then she'll turn it over to Gloria, who will go through, and many of you have seen this already, the driver diagram and the change packet. Nothing has changed, but we want to discuss that in detail, make sure that's well understood, and answer any questions regarding that. And we will probably, I think around that time, we'll have some breakout sessions to talk a little bit more in detail about the driver diagram and the change package. I think that will be very interesting. We hope to have maximum participation in that discussion. And then I'll come back on, I'll talk a little bit about what I think a lot of folks are interested in is how do we enter the data? What are we looking for? What's our strategy? And then Mercy will specifically talk about the utilization of REDCAP, which is where all of our data will be stored. It's a very robust data collecting system. We've done all of the hard work for you, so you don't really have to worry about how to enroll in the REDCAP. We'll go through all of that and make it very, very simple for you. And then we'll end with where do we go from here? What are the next steps? And answering any questions towards the end. Let me just give some administrative announcements. So if you would, just in the chat box, just kind of put your name, what your role is in your organization, and then what organization you are affiliated with, so that we can know who's here today and be able to identify you by name and organization. And then as we go through the presentation, if you have questions, just put those in the chat box. I don't think that we'll be able to unmute your mic until we go into the breakout session, just for so that we can keep the presentation rolling. So please put all your questions in the chat box as well. And then let me just introduce our work group. These are the folks who have been working hard behind the scenes on this particular project. Again, for this project, I'm the co-chair along with Dr. Chari, who is a emergency department physician. And so it's good to have OB and ED, since this is a collaborative project between those two groups. Sue Butts, many of you know, and she's here today to answer any questions. Sometimes people get a little afraid about quality improvement project, and so she's sort of our expertise, and she'll be here throughout the course of today's talk. I talked about Gloria. Dr. Epps is here today as well. She is on the faculty. She's also very instrumental in reigniting TEXASAIM, which all of us are very excited. The hypertensive TCHMB hypertensive aim kickoff has already started, and there are a number of different learning collaboratives coming up that many of you may already be aware of. Dr. Ramsey is also the TCHMB Chief Medical Officer. I mentioned Mercy Naglis here, Julie from TCHMB as well. Divya will be available, who's also been involved in the neonatal TCHMB project. And then we have a number of other folks that are listed here, to include Dr. Davidson, who I think will be joining us for some time, and Dr. Haddock as well. So got an exciting menu for you today, and I think that we will go ahead and get started, and I'll turn this over to the Gloria. I'm sorry, Lolly. And Lolly, if you're on mute. Lolly, are you there? I think you're on mute. Are you there, Lolly?
I think we're having technical assistance. I don't know, technical issues. I don't know. Dr. Epps, can you?
I can't. Lolly, it's going in and out. So I was going to jump in. And if you get the reception working, please come back and interrupt me and start at any point, unless Jim or Gloria want to jump in instead.
Go ahead, Carrie.
Okay, I might need to hear.
Most of these slides are ones we talked about before, so
okay.
We're here.
So we have talked with you all before about the reasons behind why this project is so important. We're going to go a little bit through kind of alignment with other state issues, but as a reminder, our own state morbidity and mortality review committee, in the prior report and in the report that was just released, has had recommendations surrounding the importance of integration between emergency and maternal health service coordination, and to be able to implement evidence-based protocols to appropriately identify and manage obstetric and postpartum emergencies. So of course, the recognition and appropriate management of preeclampsia in the postpartum period, we know goes predominantly into our emergency departments in our state and is such an important piece, and something that obviously our state MMMRC has seen in the reviews they've done. Recommendations from them include the commentary that this is a common pattern that they've seen, and that there might be gaps in emergency providers' knowledge about maternal health, and the important pieces about communication and timeliness of treatment. We know, for example, that A blood pressure of 160 over 110 might not be an emergency in a 70-year-old male who has chronic hypertension, but it is in a postpartum woman who has no history of hypertension and is indicative of preeclampsia with severe features. So we hope this project will help to meet that goal for our state. Next slide, please.
I'm back, if that's okay.
Yes, go right ahead, Lolly.
Thank you, Dr. Epps. So, as far as our goals, firstly, we have to identify the postpartum patients. And
Lolly,
Is it-
Hey, Lolly.
there's
let me leave the.
If it's okay, guys, I'll take over. I will see if Lolly can fix the background check. So yes, we can stay on time. So as Lolly was mentioning this, can you guys hear me? The project goals is going to identify in postpartum patients presenting to the emergency department with severe hypertension or preeclampsia. Treating patients identified with severe hypertension in a timely fashion. Improving communication and coordination of care between emergency medicine and obstetric healthcare teams, reducing complications from postpartum preeclampsia that led to maternal morbidity and mortality, and reducing disparities in health outcomes of Black and or Hispanic postpartum patients with severe hypertension or preeclampsia. Next slide, please.
Hey.
Are you back? Oh,
Third time's a charm.
okay.
Can you hear me now?
Yeah.
Okay, I just have to get in here, right? So here's our aims, our SMART aim, and our short-term and our long-term aims are designed for September 2023. The emergency department on our short time aim will increase patients. As we said, we wanted these patients to be identified. So we want to increase screening of these patients, those that are identified with elevated blood pressure from a starting baseline, and to increase by 2023 this identification by 50%. The long-term aim is also to increase by 50% all the patients, the case reviews that we are conducting, the coordination. We talked about coordination between ED and OB. So those case reviews, we hope to increase the case reviews by 50% from the baseline. Next slide. And Dr. Epps, I can let you back on this one. I believe you developed this beautiful slide. So would you like to do this one?
I didn't. It's part of our TCHMB plan, but yes, absolutely. So this is how we plan on our AIM efforts and our TCHMB elements efforts aligning. We know that a critical part of the AIM hypertension bundle includes coordination for care for pregnant and postpartum women in all areas of the hospital, including in the emergency departments. And so while the group of hospitals that is participating here, we hope to do much more in-depth implementation assistance and peer learning and data submission and in-depth QI work together. We also hope to pass on all the things that you all learn and are working to the rest of AIM hospitals in the learning sessions. And so to bring pieces of this project into those sessions so that people can be working on those AIM elements. But you guys will be doing much more intense QI, which we hope means very robust lessons learned.
Okay, and so the PPD alignment, as you can see, that we are closely aligned with the with all the departments, TEXASAIM, as we spoke of, and the TCEH PPED, and we are aligned as far as the evidence-based procedures, role-specific education for preeclampsia, and doing drills and debriefs, and reminder for the EDs that this is also helps to align with requirements for Joint Commission with the drills and the debriefs, and multidisciplinary review of severe hypertension cases. That's kind of the meat and potatoes part of our large aim is to review ED and OB to work together on these cases, review, and educate and support patients regarding severe hypertension. Next slide. So again, TEXASAIM and PPED, as was described earlier, we work together, we collaborate on this. The scope for both TEXASAIM and for the TCHMB is for severe hypertension. The TEXASAIM project is related to all phases of pregnancy, and the TCHMB PPED, as described, is primarily focusing on preeclampsia for patients in the postpartum period, presenting to the emergency department. For TEXASAIM, the data submission will be through TEXASAIM, and the data for the TCHMB will be through REDCAP. And it's a statewide project for both. With the with the PPED, it will be through URACS, as we stated earlier, in collaboration with TEXASAIM. The activities are similar. They're both quality improvement projects. And the primary department for the TEXASAIM project is OB, the OB department, whereas, and they will be doing projects and in-person work groups, as opposed to the TCHMB will be focused on the emergency department in collaboration with the ED, and will be primarily virtual and data submission. We'll talk a little bit more about how they will do their virtual submissions and calls with the QI nurse and technical assistance through TCHMB. So they overlap because it is part of the TEXASAIM hypertension bundle. All right, next slide. So what's up? A calendar today is our first webinar. Thank you so much. We have so many wonderful participants here. We hope that those of you who are not enrolled are encouraged to enroll if you are not. And in February, we're going to be with the TCHMB pre-summit and summit, the 15th through the 17th. In March, we will begin our first monthly reinforcement calls. The reinforcement calls are for the people that are in the reinforcement group, and those are the people that will be the group that will be the cohort that will be submitting data. The technical assistance groups are also encouraged to be part of the project. They will have all the same help and technical assistance, but not required to submit data through the REDCAP. March 9th is the first series of our calls. And then we talked about baseline, establishing a baseline and increasing, hopefully by September 23rd, our baseline of identified patients and the collaboration of the case reviews. So we want to start that in March, and hopefully we can be submitting our data, our monthly data, in April, and we'll have that data due every month, the 15th of every month. Next slide. So we will have action periods, not necessarily in person. The PPED will be primarily virtual, and the findings incorporated into TEXASAIM. Next slide. There will be support between monthly calls. We'll have office hours that for optional calls for anybody needing assistance. The QI nurse is to help with this, since it is a quality project, to help those who want technical assistance or any help with the PDSAs, and provide feedback on the data submitted, the data that needs to be submitted, and links to resources and communications. Next slide. So I mentioned earlier that goal 5 of the project is to reduce racial disparities in health outcomes of Black and postpartum women with severe hypertension or preeclampsia. as a result, health equity will be a focus of this project. And that's what I'm done. Third, finally, thank you for waiting for me. That's all.
Thanks, Lolly. And we'll turn it over to Gloria.
Hi, everyone. So we're going to be reviewing the driver diagram and the change package. Most of you are familiarized already with that or have seen at least the driver diagram. So we can go to the next slide so we can show the driver diagram to everybody. Okay, so on this one, you see we have an aim, which is different to the goals that we have for the project. So the global aim is coordinate emergency care for postpartum patients experiencing signs and symptoms of postpartum preeclampsia through TCHMB's partnership with the Regional Advisory Council, Perinatal Care Alliance Emergency Care. This is your RACs, okay? So that's the global aim. The project aim is by September 2023, emergency departments will increase patient screen for postpartum status for elevated blood pressures 140s over 90s and symptoms of preeclampsia by 50% from hospital baseline. So it's going to be according to what is in your hospital, okay? So we're going to go, I'm going to explain you the primary drivers, and then we're going to go on the breakout groups where we're going to talk about the secondary drivers. So not everybody's going to be able to see all the secondary drivers. You're going to be assigned to one of the groups and you're going to be discussing the secondary drivers for that primary driver. So primary drivers are prepared staff, and that's for readiness. And if you notice this is similar to TEXASAIM. We're matching what TEXASAIM is doing. So we won't have to deviate from that model that we are using already. Triage and evaluation, which is recognition. Treatment is going to be the response to what's happening to the hypertension. Care coordination, teamwork, and communication response. And the last one, it will be culture of equity and quality improvement reporting and system learning. So you look on the right side, we have the secondary drivers. So I'm not going to go through them. I mean, you guys have them. We're going to actually go into, I think the next session is going into breakout groups. And we're going to have 10 minutes to go and discuss what have you hospitals are ready for that, or what is that you're having challenges with. There'll be some questions in there that we're going to address. So if we can go to the next slide so I can, okay, there you go. So it's going to be 15 minutes. We're going to talk about the secondary drivers on these groups, okay? You're going to be assigned, so I don't know which one you're going to be on one of the 5 groups that we have. We have 10 minutes to explain what changes has your hospital already implemented or are currently testing, what challenges might hold you back from testing and implementing all of the changes, ideas, and strategies, and what change ideas or descriptions, puzzles, or confuse you. So once you go into your breakout group, you guys have to select either the first person that logs in or the last person that logs in is the one that is going to give a quick review, a 1-minute review of what we talk about on this session when we come back, you know. So I'm not sure we come back, but that person is going to be the presenter. So we're going to show you once we're in the breakout groups, they're going to be the secondary drivers in there, and then you guys can start talking about, this is going to be a discussion of, once again, these 3 questions and what is done, and maybe you're going to get ideas on how you can start also on your hospital. Unfortunately, we cannot rotate you through every group. So this is the first time, so we'll see how it goes, guys. Okay, so here we go. Can we go into the breakout room?
What we talk about in this particular slide is we have 2 outcome measures. The first one focuses on screening all of the patients who've been identified as positive for postpartum and have elevated blood pressure. That's the first outcome measure. The second one focuses on the case reviews, and we talked a little bit about this in our breakout session, doing joint case reviews between the ED and the OB units on all postpartum patients present with a blood pressure greater than 140 systolic or a diastolic blood pressure of greater than or equal to 90 in the emergency department. And then the next three structure measures focus on the other thing that's been pointed out has been important, and that is focusing on policies, right? And then education of the staff on how to triage, who to triage, and what's important in that triage. And then the other thing that we've always been talking about is focusing also on consultation, who needs to get admitted, and focusing on treatment. When do you treat an elevated blood pressure? And then looking at symptoms of preeclampsia. What's a headache in a woman who just got released from the hospital that was diagnosed with preeclampsia, or a woman who has chronic hypertension who returns to the ED with a severe headache. And then lastly, the final measures that we have listed on here, these are process measures. These process measures are related to screening, they're related to treatment, and they're related to the transfer of those patients to the appropriate unit in a mom who has persistent severe range blood pressures. That is a systolic greater than or equal to 160, or a diastolic blood pressure that's greater than or equal to 110. And then lastly, the process measures are to align with the health equity focus on the project, the outcome, and then the process measures would then be disaggregated by race, ethnicity, language, and geographic location. Next slide. This one looks at talks about the data collection that we're going to do, and I just want to briefly highlight that we're going to do, there are going to be two forms. One's going to be an aggregate data collection form, and the other one will be a de-identified patient-level data collection form. And I'll go over those in more detail here on the next slide. Next slide. So the monthly aggregate and the de-identified patient-level data will be submitted using what's called REDCAP. And some of you may be familiar with that, some of you may not, but we'll walk you through that. And then as Lolly Perry talked about earlier today, during her discussion when she talked about the project structure, the data that we submit through REDCAP is only for the TCHMB project. So it's going to be separate than what your data collecting and submitting through TEXASAIM. So what we've asked the teams to do when you did your enrollment form, we asked you to select a technical leader or a REDCAP account holder, right, on that enrollment form. And so that particular person that you selected will be given access to the TCHMB's REDCAP to enter the required or needed data. And then that person will get an email from REDCAP asking them to create an account. Once that account is created, then they'll receive two other emails giving them access to both of those forms, the monthly aggregate and the de-identified data collection forms. And once they have access, then they'll be able to go in and enter data into both forms on a monthly basis. And we'll give you instructions on how to access REDCAP. I think Mercy will go over some of that here shortly. How to complete the forms. Some of that is also in the data measurement and data strategy guide that we have on our website, and we'll share with you. That'll be in the Basecamp site. And then don't get frustrated with it all, because we'll have staff available throughout the office hours that we'll talk about later that can help and assist you with any REDCAP questions. Next slide. So in this particular slide, this looks at the data flow. What will happen is you submit your data through REDCAP, and then our TCHMB staff will then take that data, clean it up a little bit, analyze it, put together some draft reports that look at the project's progress. We'll monitor the outcomes and then do a comparison for the group at large in sort of an aggregate form. We'll share those reports, we'll share that data with your RAC perinatal committees, with the hospitals, so that you can present that at some of your QAPI meetings. You can use it for any quality improvement in your hospital, in your region. Hospitals and RACs can then share the data reports with each other. And I think that'll help all of us throughout Texas and also in each of the regions to maybe try and get better at what we do. Next slide, I'm going to turn it over to Mercy, who is our program manager, to talk about REDCAP in more detail.
Sure, thank you, Dr. Hill. So I'm just gonna share my screen and walk you through the process of logging into REDCAP after you've received your account information, and then completing that PPED monthly data aggregate form. So as Dr. Hill mentioned, we do have guides available in our data measurement and strategy guide. And our staff will also be available during office hours throughout the project, and available via phone, email, to assist you with that completing the data. So let me go ahead and share my screen, and then I will walk you through that. All right, so once you've gotten access to REDCAP, again, that will happen once the enrollment form has been submitted and the data usage agreement has been submitted. You will receive an email letting you know that you've been given access and to go ahead and create that account. You'll also receive another email, again, giving you access to the forms that we have. So we have 3 data collection forms at the moment. So the first one is that intake assessment. Some of you might have already completed it, just given where you are in the enrollment process. And others might have not, and that's okay. We'll work with you to get that done. The next one is the TCHMB PPED de-identified patient level data collection. And then the third form is the monthly data aggregate data collection form. So I'll just use the monthly data aggregate collection form as an example. But once you log in, it'll take you to my projects, and then you'd be able to click in. And then if you were going in to fill data for that month, you would click Add Edit Record, and then Add New Record. And then this would pull up the form for you. So you'd be able to go in, enter the day, select your hospital name. Let's see the day. Select your hospital name. The form does pull up information as you type. If you enter something, it'll pull up a couple hospitals with that information, again, to hopefully make it a little bit easier for you to find your hospital so that you don't have to scroll all the way down. You'll notice that some of the fields have like the red star with must provide value. So that's something that will be required for you to enter something before you can submit the form. So you'd go in, the person who's filling the form probably will be your technical lead, again, because that's just the person who has the REDCAP access. Certainly, it can be someone else pulling in the data and then handing it to that person. That's perfectly fine. But most of the time, I feel like we'll see that technical lead being the person to complete. And then you would select the data collection period. So if this was for baseline data for September, I would go in and select September 2022. And then for the rest of the sections, actually, it's related to your outcome measures. So that's 6A is talking about the goal you wish to achieve once we kick off the project in terms of after that baseline data has been collected. So that's something you'd enter your goal there, And then the other questions are related to, again, the data that you'd have collected for that period. So the questions starting at 6B related to the number of total patients capable of pregnancy, you can go ahead and enter that in there. And the good thing is, like, based on the information you enter over here, TCHMB staff will be able to receive that data and then analyze it and create some percentages for you, again, based on what you enter here. And then again, once we get to past the baseline data submission and start that PDSA focus, this is where you'd go in and enter that information. So again, the red ones, you have to provide a value before you go in. The good thing about the form is, like, if you get started and you need to do something else, you can save and exit and it'll allow you to come back. Once you're done, I didn't enter values for all of that, so it'll not let me move on. But you can go save and exit record to submit. I did not. Yes, so you enter that. And then it would come to us and we'd be able to analyze that information. Like Dr. Hill said, we will be sharing the data that you enter during the data collection periods and any reports that we run with you. And we're certainly available to answer any questions. I know this is a fairly quick tutorial, but like I said, we have a guide and we're available for any questions you may have. So with that, I'm going to go ahead and pull up our presentation again and then turn it over to Gloria for our next steps.
I'm back, guys. We're going to go into next steps. So once we get, there you go. Okay, so our next steps, January to February, we are asking the hospitals to complete enrollment steps, review that driver diagram and change package that is sent to you when you apply, review the measurements and data strategy packet and identify data sources for your hospital. From what we heard, at least on the breakout group, a lot of people is already in that part, and they are able to collect some of that data already. Access your REDCAP account and make sure you can navigate the system. And remember, we have our, well, let me see, the January 26th, we have our TCHMB OB committee meeting, and that's for the RACs. And so make sure that your RAC representative is there, because we can give the information to them, and then they bring it to your local RAC meeting so you can get all the information that is presented. March 2nd at 5 p.m., we're going to have the first reinforcement call, and it will be monthly, the first Thursday of the month. And remember, we have the phone calls, the office hours, that if you have questions, you can call us. So that will be, starts on March 9 at 12, and is the first office hour is bi-monthly, every second and fourth Thursday of the month. And then on March 15, we're going to have baseline data from September 1st, 2022 to December 31st, 2022. We'll see how much cases we are able to track on those on that quarter, which is that just passed. And so it will be doing REDCAP. So we'll see how, it's a baseline. So whatever number of cases that you can get in there, so you can get familiarized with the system, and also to hopefully can be as accurate as possible. But I know it's going to be a little bit challenging because it's prior quarter. So I think with that being said, I don't know if, next slide, please.
Just 1 second. I'm sorry. This is Audrey Thompson. I just wanted to mention that TEXASAIM cohort 2 actually has an in-person meeting on January 26th from 8 a.m. to 5 p.m. So it may be difficult for the members of cohort 2 to attend the meeting, the TCHMB OB committee meeting.
That one is actually the RAC representative.
Okay, so it's not for this project then?
No, it's the RAC.
Okay, sorry. Sorry about that.
Yes, no, that's fine.
Okay,
yeah,
thank you.
I know that, like, I'm cohort 1, so I know we go next week. to our TEXASAIM. So I know it's like all of us in Texas is so big that, at some point, one of the meetings are going to be, we're trying to coordinate with TEXASAIM, by the way. So, and Dr. Epps is with us, so she can guide us pretty well. We're trying just not to interfere too much with TEXASAIM, and then we'll be a representative from TCHMB on those TEXASAIM sessions, so they can present what the project is how is it going, and what the updates from TCHMB PPED. Okay, so
Okay, perfect.
we will collaborate with them. Okay, so we will. Thank you very much. Another. I just got muted. I don't know if you guys can hear me now. Okay, PPED project work group members, TCHMB obstetric committee members, the RAC PCR Alliance, and we have had meetings with their leaders of the RAC representatives, the executive representatives with the RACs for each RAC, Texas Department of State Health Services, and TCHMB partner organizations. Like I said, we're collaborating with them, and Dr. Epps is with us, so it helps us to stay coordinated with them on the meetings that they have. Next slide, please. And we would like to invite everybody to our summit, February 16 and 17 for the TCHMB. This is a live summit. It will be in Austin. So I think the link is to register. It will be next. If not, it will be on our website. But it's a live. The topic is social determinants of health. That's a topic that is coming up. Actually, Joint Commission is requiring us to all the hospitals to start reporting. I think it's going to start in July, that we're going to have to start reporting on that matter. So it will be a great opportunity to see, how we can improve our services and how we can implement this new topic to all the metrics that we already using or tracking for our hospitals. So all of you are welcome to attend, and hopefully we can see you there. Next slide, please. Thank you. I don't know if anybody else wants to add anything else on the meeting. We have, I thought that part was going to take, the REDCAP was going to be a little bit longer. I don't know if anybody has questions, because we had time left over. So in case you want to have some questions, put it on the chat so Mercy can answer. I don't know, we can open it to the group if they can raise their hand, and so they can ask questions.
Yes, everybody can ask questions if they want to.
I don't
Hi,
know.
guys.
Go ahead.
Sorry, Gloria, this is Mackenzie. I feel like I've talked a lot, but I'm curious from the ED physicians in the group, how, if in your hospitals anybody's done anything, I'm trying to get buy-in and agreement from my ED physicians and alignment with the OB population and OB physicians. And it, as a maternal program coordinator, i.e. a nurse, it's hard for me to say, well, these are the recommendations from ACOG and AWAN, like, this is what I need you to do, because they tend to want to do what they think is appropriate in the ED. So I feel like that's a barrier, and I'm not sure how to break through.
Are you asking anyone, any ED physician to answer, or are you asking someone in particular?
I was curious from anybody, but I thought we had some ED physicians, so I would love to hear from your perspective how best I could approach and collaborate.
So for my hospital, I'm in Memorial in Katy. We have I'm on the committee, so I represent the ED whenever we have a meeting, and after we discuss, I take it back to my ED team. Basically, whatever we discuss, or what, for instance, I'll just give an example. Every pregnant patient that comes in that's 14 weeks or above, we in the ED physician always calls the OB hospitals, the OB-ED hospitals, to let them know about the patient. Doesn't mean that they will intervene, doesn't mean that there's anything for them to do, but just that they're aware, and if they choose to, we can work together on the patient. So that's standing right there from the beginning. And also postpartum patients up to 3 months. So we wouldn't necessarily need someone like in your position to try and emphasize things when the ED physician that's representing the group is the one bringing it back to the medical director and bringing it back to the team. So it kind of like removes that problem that you have because of the way that we have the team created. I don't know if that helps or if that answers your question.
Yeah, that's great.
Ms. Christine Reeves has her hand raised.
Mackenzie, I don't know which regional advisory council you're in, but what we did was use our OB, who happens to be our MFM. She's our champion. We had her meet with our physician group as a region and talk about the project for 2 quarters of our meetings. And it kind of got everybody understanding. And then when the nurse managers went back to kind of have those discussions at the facilities, it made it a little bit easier because they were getting information from a physician colleague, both a MFM and an emergency room medical director at our lead level 4. And then when the nurse manager came from their facility, they kind of were getting it from both sides. We don't have everything worked out, but that seemed to work the best for us in our region.
That's a great idea too. Thanks so much for sharing.
Sure.
What I can suggest to as a hospital, not as part of a TCHMB or co-chair, I think that RACs, you need to involve your RAC executive leader because they have a group with the ED. They have meetings with the ED. So if your perinatal chair can go and talk to that meeting so they can know, this is what's coming up from the state, and RAC is requiring you to participate, not requiring, but suggesting for you to participate, number 1. Number 2, Joint Commission is going to be asking them, and those of you that get Joint Commission, I know that not everybody is surveyed by Joint Commission, but one of their standards is what you're doing with postpartum patients with hypertension, and they also talk about postpartum hemorrhage, but for hypertension. So that's another way that you can address it with them too. I think you need to help the hospital through the RAC. And the other part would be if you can go and attend that meeting at your hospital. Like for us, what we're doing is we did like the nursing part, nursing administrators were talking with the OB and ED, and then we're having our MFM or or obstetric lead doctor go and talk to the ED doctor. So doctor to doctor and nurses to nurses. Hopefully that way you can get some buy-in for that project. I don't know if anybody else has any other suggestions how to get that ED team collaborating with OB.
This is Dr. Catherine Corvesses. I'm at Memorial Herman Katie as well, so I work with Dr. Akajobi. But in addition to her being on our part of our chart review process and taking that information back to the ED, I also I just kind of invited myself a couple of years ago to our ER ICU meeting where all of the, directors are there. And whenever we have fallouts for patients, we present those and, talk about what we need to do to improve. So, I think as a medical director, you just have to join the other meetings with the other medical directors. So if you have something like that available, then you should become part of it. And, using the point that you have the Joint Commission initiatives, I don't think your administration is going to, give you any problems.
Yeah, I think those are great ideas. I think the other thing that, and I think with my group, I mentioned the same thing about a young lady who was pregnant and came into our ED after a motor vehicle accident, and a lot of things weren't done the way they should have been done. And so we reviewed that case. It went to peer review, and of course got reviewed by the OB team and the ED, and as a result, we've done a lot of things differently. We've invited our OB colleagues to their trauma meeting. We've invited the OB colleagues to our ED meetings, and then we've invited the ED docs to our coffee meeting. So, and none of us wants to have anything bad happen that it goes to peer review that requires us to intervene just because of that. But the other thing this can be discussed with the executive team at the medical executive team committee meetings, where you've got to have an OB. I'm sure there's an OB chairperson on that medical executive committee that can speak to the importance of this project. And you've always going to have an emergency department chairperson at that meeting. And so at some of the larger administrative meetings, you should bring some of that up as well. Simulation is the key for us, and to educate all different parties, both from the ED, from trauma, from OB, the OB hospitalists. Everybody gets involved and everybody gets educated, and nursing as well, so that everybody sees the importance of their role in preventing these bad outcomes. Other questions? I don't know whether Gloria, you're still on.
I'm still here, but no, I don't have any
Okay.
questions. I don't know if anybody has any questions, or if there's no more questions, maybe we can release everybody 15 minutes earlier. Or Ms. Sue, do you want to share any information with us?
Did you ask me, Sue? I'm just sitting here pondering the idea of buy-in. It's a hard one, but we'll work on it together. That's the exciting thing. It seems like there's a lot of folks who are experiencing that, and we'll definitely probably have more conversations around that. And that's the beauty of testing too. Dr. Hill mentioned we'll be learning and testing using PDSA cycles and kind of learning our way to implementation. And that sometimes gives people who are resisting chance to experiment a little bit, see what some of these changes feel like, and hopefully gradually that buy-in comes. But I'm a fan of simulation as well.
Gloria, this is Lolly. Could I make one quick comment about almost universal feedback from our breakout session, and something maybe we can incorporate into the learning groups? One of the biggest challenges is turnover of staff in the ER. So it was just astounding that they had so much turnover. It was difficult to train people and then have new people again. So maybe that's something we can work on as well.
That's a good point, Lolly. And it's always frustrating and sometimes difficult to feel like you're going to start all over again, right? So you've done this, we've done this, but then you lose some of the key folks who've been helping to be the glue to keep this the organization and that collaboration between those two units together. But you got to stay at it. You got to keep at it. You got to keep doing the drills, and you got to keep emphasizing and educating so that you don't have any missed opportunities to succeed. Gloria.
Okay, I think if there's not any more questions, we could adjourn. Just please, for those of you that have not applied, we highly suggest you to please apply. We wanted this project to be like a statewide effort, so we can see what is the true state of Texas, as far as postpartum hypertension. And also for the January 26th, remind your RAC representatives, those that can attend, if you're in group TEXASAIM group, second group, I know you might be not able to attend, but those that can, please attend. Remind your representatives were there. We can give more of the information in there. And if there's any additional invites, any additional meetings, we will let you guys know. But thank you, everybody, for attending. We're very glad to see you guys.
One quick thing, Mercy, if you could reach out to Teresa in the chat. She's asking how to apply. So.
Yes, great. I will go over the chat and any questions we were unable to get to today. I'll work with the work group to answer those and then send that out in a follow-up email. So I'll definitely touch base with you, Teresa.
And then we'll also get the PowerPoint out, as Mercy mentioned before. Okay, Gloria.
That's it. Thank you very much, guys. And you know, we have a website that www.tchmb.org/PPED, and you can see our website in there, and like information will be there posted too on how to apply and everything. So, but we'll send that. Marcy will will send you guys the PowerPoint presentation. So thank you, everybody. I hope this was helpful. I don't know if anybody else wants to add anything. Otherwise, we are adjourned.
Thanks, Gloria.